Welcome. I'm Dr. Leon Popovitz. Today I am honored to have my first guest is Dr. Michael Mizhiritsky, my very good friend and one of the most foremost spine specialists in the entire nation. Welcome.
Thank you. Thank you, Dr. Popovitz.
You're welcome.
It's too kind of an introduction, but I'm happy to be here and happy to be the first guest.
Good. I'm glad. So let's get right into it. You know, medicine is just changing on a super rapid pace. It's both practically and academically and every level. But what are you seeing as far as the main concerns that your patients are experiencing?
Well, as a specialist, I usually a lot of times get a second opinion or an opinion that primary care doctors may not know the exact diagnosis of. So even with the testing, without the testing patient had, there still may not be geared or at least directed in a position where they should be treated. So the main concern for the patient, it always has been, but even more so now, is to get better, but get better quicker. People want to be in, people want to know what they have, the diagnosis, and they want to get out fast. And they obviously want the best possible care and timely care and inexpensive care at the same time, meaning that they don't want to go forever. They don't want to have complicated procedures. So that's where I come in to try to explain to them what needs to be done and hopefully direct them in the right way. Yeah.
So you feel speed, promptness in getting better now is become almost parallel to the age of the phones, that people are eager to always eager, okay, you want that next step. So you feel that has translated into medicine where patients don't have that same willingness to kind of let the process go, but they want everything expedited. Do you feel that's the case now?
Absolutely, especially the younger generation, especially the generation between 20 and 45, 50 years old, that they need to get out and do their things, that they need to work. So they really want to come in and get the right possible care immediately. So walking in and seeing a specialist or a primary care sports medicine physician initially actually does help before the workup is completed. And then to a subspecialist, when a patient comes in, there's already some information where we can guide them in the right direction, and also done quicker, given especially in our clinic at New York Bone and Joint Specialist, we have everyone starting with the primary care sports medicine doctors to the top specialists and surgeons.
It's interesting how things have become now so compartmentalized, right? So you have a gatekeeper to do the full evaluation, and you have the subspecialist. For instance, once a particular spine condition has been diagnosed, then it's turned to the subspecialist if the condition requires. But it also seems as though that things or treatments are even quicker now. Things are becoming a little bit more expeditious now, whether it's medications or procedures or testing. For example, I mean, for like nerve conduction testing, you can determine if there's any major nerve damage right then and there on the spot.
Absolutely.
Tell us about the nerve conduction studies.
Yeah, absolutely. I'm glad you asked, because I do specialize in EMG, electromyography, and nerve conduction study testing. So I'm just going to lead with one interesting example of a patient that I saw recently. Late 30s, young lady, administrative assistant, was referred to me by one of the primary care sports medicine doctors for this diagnostic study, thinking she may have a condition called carpal tunnel syndrome. Carpal tunnel syndrome is something we've all heard of. It's pain, it's tingling, it's numbness, it's into the fingers, it's in the wrist. It could be somewhat nonspecific, but she did have tingling and numbness in the fingers, the first three fingers, the thumb, the index, and the middle fingers, which are very typical in carpal tunnel syndrome. And the symptoms were worse, not just when she was working, but when she was waking up in the mornings. Actually was waking her up at night as well. So she really didn't have any other major symptoms except for the tingling and the numbness. So she thought that she was having carpal tunnel syndrome. She was referred to rule out carpal tunnel syndrome. But this is where the specialist comes in, just to be clear that EMG electromyography nerve conduction study is essentially an extension of a physical exam. So we need to perform a physical exam. Obviously, you have to take in the proper history. So besides the tingling and the numbness, which she now had for a few months, she does have a little stiffness in her neck. And it's usually worse in the mornings as well, but really no other essential symptoms. On exam, her strength was good, and maybe just some sensory loss. So when I went on to do the nerve testing, I found that actually she did not have carpal tunnel syndrome at all. And her nerve, which the median nerve is the one that's affected and compressed, the carpal tunnel syndrome was perfectly normal. But then as I continued to do the test, I found that what she did have is a pinched nerve or two pinched nerves in her neck, affecting the C6 and C7 regions. And those are the muscles, those are the nerves that go to the muscles down the arm and into those three fingers. So it can easily be confused for carpal tunnel syndrome. And obviously, if the patient never had this test, she would be treated for carpal tunnel syndrome with a splint. She would waste time, she would lose time, she would think that that's all she is, while her pinched nerve in the neck is getting worse. Now, most common pinched nerves in the neck happen as a result of a slipped disc, a disc herniation. When the disc slips, it can actually continue to get worse if it's not corrected or managed properly. So again, in this lady's case, if the care would have been stalled for we don't know how long, and even though she didn't have any weakness when she presented to me with the mild symptoms of tingling and numbness, 3 months from now, she could have presented with other major issues like weakness, or even worse, some other bowel and bladder issues. So thankfully, we caught it early enough, sent her for an MRI. She did confirm on the MRI that she did have herniated discs specifically to that area, to that level, and then we started the proper treatment. So on the follow-up immediately after the MRI, we talked about different treatment options.
Very interesting. So now we're talking about two different diagnoses and how you can promptly determine or differentiate between the two with that nerve conduction test. Let's just backtrack a little bit on and talk about each one of those individual conditions. So carpal tunnel syndrome. What is carpal tunnel syndrome?
Absolutely. So carpal tunnel syndrome is what's called a compression neuropathy. Neuropathy, neuroneuropathy, disease of the nerve. Obviously, compression is something that's pressing specifically on the nerve. So it's the most common compression neuropathy in humans. So it's a compression of a nerve called the median nerve at the wrist, and that nerve goes to several muscles in the hand, and it also goes to the several fingers, specifically 3.5 fingers, sparing the pinky and half of the ring finger. So it goes to the thumb, index, middle finger, and the other half of the ring finger. That's the median nerve. When there's compression, it's called carpal tunnel syndrome. Now, carpal tunnel syndrome, there are different degrees of carpal tunnel syndrome. We usually grade them as mild, moderate, or severe. And then depending on what we find and how severe it is, specifically on the nerve conduction test, then we discuss treatment options.
So the carpal tunnel syndrome is the compression of the median nerve at the wrist. There could be 3 different degrees of it. Once the compression occurs, the main symptoms are the numbness in those 3 fingers. Do people feel weakness? Do they get weakness?
Well, that would be more advanced carpal tunnel. Initially, it's, as this young lady presented with just tingling and numbness, it could have progressed to be weakness, even though she didn't have carpal tunnel syndrome. So it's, I guess, somewhat of a different subject. But yes, if we found carpal tunnel syndrome and it was just tingling and numbness, that would be probably just a mild case.
So more later stage.
Correct. Yes, later
condition.
Stage. Weakness and atrophy, wear and tear of the muscle.
Compression of the nerve, different stages. Early stages is usually numbness, and then as it progresses, it causes weakness or maybe even atrophy of the muscles. Now, once it's diagnosed, the best diagnosis would be a nerve conduction test. Once it's diagnosed, what are some of the treatment options?
Sure. So carpal tunnel syndrome, we want to catch it early. The reason being is, unfortunately, there is no specific cure for carpal tunnel syndrome short of surgery, which I'll discuss in a second. But if it's caught early enough, we can actually treat it conservatively to at least prolong the time from the patient to have the surgery. So if the patient only has some tingling and numbness, and the nerve conduction study, the EMG, confirms just mild findings, we don't rush into recommending surgery at that time. We splint, we brace the patient. Sometimes we consider an injection, which can help for up to 6 months. It's not a cure-all, but it can help for up to 6 months. And we try some hand therapy, hand therapy to strengthen strengthen all the muscles in the hand specifically, and also to teach the patient what to do and not to do with that wrist, hopefully preventing the carpal tunnel syndrome from getting worse. Now, if we see more advanced cases, moderate to severe carpal tunnel syndrome, surgery really is something that should be strongly considered because, again, carpal tunnel syndrome does not go away. And with surgery, the success rate is very, very high unless it's very severe. So we don't want it to be very severe because there's a lot of the nerve loses its supply to the muscles, and the more the loss, the less chance of full recovery. So we want to try to catch it early enough, but if it's moderate, it's still fully reversible through the carpal
if
tunnel.
surgery is going to be an option, it's best to do it before the nerve is permanently damaged and not irreversible.
Right.
So if sometimes the surgeon can release that pressure on that nerve, and the nerve can come back and regain its function. But if it's gone too far, unfortunately, so just to review, so that's carpal tunnel is compression of the nerve at the wrist. Symptoms are numbness in those three fingers. If it progresses, it could be weakness and atrophy of the muscles. Treatments are usually splinting, occupational hand therapy, maybe an injection, some anti-inflammatory medicine possibly. And if that does not get better, ultimately surgery is a reasonable option, but you always want to make sure that you're watching the patient. The patient's being monitored closely, so it doesn't get too bad before.
That's exactly right. So the patients that surgery is not recommended for immediately, we'd like to see them back 6 months to a year later to do the quick nerve conduction study and compare to the previous one to make sure there's no progression. Patients may not feel they're living with their body, so they may not feel much of a difference, but the nerve conduction study will tell us if there is or not. So yes, those are not surgical. We try to see them back.
Now that, like you mentioned, can present very similarly to a pinched nerve in the neck, extraordinarily. Because what? Because it's essentially the same nerve, but now it's being pinched higher up. Is that right?
Exactly.
So what are some of the causes of the pinched nerve in the neck? I think you touched upon it.
Yeah. So again, in layman's term, a pinched nerve is a nerve being squeezed by something, and we need imaging. We need imaging to see what causes that. Most of the time in the younger population, it's a herniation. A herniation is basically a slippage of the center of the disc, and it's going through the outer portion into the space where the nerves are exiting, coming out, before they actually become nerves going all the way down to the hand. So it's really very proximal, right at the neck, or it could be the back, etc. So most of the time in the younger population, it's a herniated disc. Now, that being said, there are many other components to a pinched nerve. Sometimes it could be a tumor. Sometimes it could be a fracture. More in the elderly population, it could be arthritis. It could be degenerative changes, and as a result, that can cause narrowing of the canal, not just slippage of a disc, but narrowing called stenosis. And it could be a combination of those things: some slipped disc, some narrowing from degeneration, causing stenosis. So in the treatment, options would be really different depending on what the condition is. Again, occasionally, as I mentioned, we find conditions such as a tumor, a growing tumor, may be benign, may not be, that's causing that pinched nerve, and therefore we obviously may have saved the patient's life, perhaps.
So just to review, a pinched nerve, so you can get the numbness in the hand if you have a pinched nerve down in the wrist. You can also get numbness in the hand if you have a pinched nerve in your neck. There's a wide variety of causes of that pinched nerve in the neck. So the most common one would be herniated disc, a popped disc in the neck, pinching that nerve, arthritis, or something like that. Now, would you get numbness only in the hand, or would there be numbness in the arm?
Mm-hmm. So that's a very good question. So the symptoms can vary with a pinched nerve. So sometimes it can just be some tingling in the thumb, and it actually is coming from the neck. Sometimes it can involve several fingers. Sometimes it can involve the forearm, the arm. So we can never assume that it's coming locally, the compression, if it's just the thumb. Same thing in the lower back. You can have a tingling and numbness in the big toe, and it's actually coming from a slipped disc in the back. And there are no other symptoms. That's the earliest sign. That's the early sign and symptom is tingling and numbness in the toe, but it's all coming from the back. So that's why it's important to have the nerve conduction study to rule in or rule out the pinched nerve before we find out what's causing it specifically.
So pinched nerve in the neck or herniated disc in the neck, causing the numbness, causing the discomfort in the arm, causing that kind of electricity feeling in the arm. Diagnosis is physical exam, nerve conduction study, possibly MRI, treatments. What sort of treatments?
Right. So I'm going to go back to the young lady I was discussing earlier who thought that she had carpal tunnel syndrome and turned out to have a herniated disc, C6-7 herniated disc. So it's important to not just discuss treatments and obviously explain to the patient what is going to be done or should be done or the options, but also to eliminate the things that may be causing it. So as I mentioned, her symptoms will worsen in the morning. Now, it's very typical and common for carpal tunnel syndrome to be worse in the morning simply because we tend to sleep in the fetal position with the wrist bent. So when we wake up, there's tingling and numbness in the hand. Now, that's why she thought it was carpal tunnel syndrome, because it was worse in the morning. She read about that. Now, upon further questioning, the way her neck was positioned was in extension. She actually did not use a pillow to sleep with. So she was sleeping in an extended position. So if she never eliminated that, no matter what treatments she had, she would not get better. There would be continuous compression on that nerve.
Just because of her position,
just because of
without
her position.
a pillow.
Exactly. So she was extending. So it's important to not just discuss treatments, but also to alleviate or eliminate the things that may be causing it. So it's important to get to know the patient and what their activities are during the day. Now, as far as the treatments for the pinched nerve from a slipped disc, almost always it is treated and managed conservatively, non-surgically. Maybe 1 to 2% of the patients will ever undergo or require surgery for cervical disc herniation or lumbar, as well as the lower back. Most of the time, as I said, if not always, patients will get better conservatively. Now, really depends on the patient, and pain is subjective and symptoms are somewhat subjective. So if the pain level to the patient is high, let's say on the scale of 1 through 10, it's somewhere in the range of higher than 5, let's say 7 or an 8, we do consider something to alleviate the pain through injections, through epidural injections. Now, the epidural injections will help to decrease the inflammation around the nerve from the disc. Now, by helping to decrease the inflammation, that alleviates a lot of the pain, which will allow patient to do a lot more activities and physical therapy. Now, physical therapy is really something that works for herniated discs very, very well. Especially if the patient's pain is not that high, they need to go right into therapy for some manual tractioning, some strengthening exercises, chin tucks, etc. And the physical therapist will be able to guide them what to do at home as well. And if they have the epidural or not have the epidural, the physical therapy will take a few weeks to maybe a couple of months for the symptoms to fully resolve, almost always.
Very interesting. So, numbness in the hand could be a carpal tunnel syndrome, pinched nerve locally in the wrist. Could also be a pinched nerve in the neck. Treatments for the carpal tunnel are bracing, physical therapy, anti-inflammatory medicine, local injections. Treatments for the herniated discs, physical therapy, very effective. Sometimes you may need a more invasive injection, called an epidural injection. And if last resort is surgery for both conditions, but again, for both conditions, it is not as common as people might think. And of course, lifestyle changes. Simple, just finding out how somebody sleeps. This day and age, everybody's looking for these sudden, immediate, dramatic treatments, cutting edge treatments, but sometimes just good old basic medicine, asking the patient how they're sleeping,
Absolutely.
is enough to potentially alleviate such difficulties and discomforts.
Yes, absolutely. So using 1 or 2 pillows alleviated a lot of her symptoms, and with the physical therapy, the patient got better
No,
very
wonderful.
quickly.
No, wonderful. Wonderful.
So save their time.
That's right. Very good. Thank you so much for joining us. It was really so informative, and I hope that you come back and allow me to interview again.
It'd be my pleasure and honor.
Yeah. Pleasure.
Thank you, doctor.
Thank you, doctor. Thank you, everyone. Look forward to seeing you again.